What's up, everybody? It is the PA Professor back with another video. Today we'll be covering the last of the cardiomyopathies, and this is restrictive cardiomyopathy. So let's get started. Again, if you know nothing about the disease, take the disease name, just break it down and interpret. Cardiomyopathy, we should all know by now from the previous two videos, this means disease of the muscle of the heart, and it has something to do with restriction, right? So let's get going. So my definition for this is this is a problem when the ventricle is stiff or rigid, and basically because it's stiff and rigid, it can't fill properly, which is causing a diastolic dysfunction. Earlier we talked about this dilated cardiomyopathy right here. This was a pumping problem, right? This was a systolic dysfunction. Well, if we look over here, restrictive cardiomyopathy, this is just a filling problem. This ventricle chamber right here is stiff, right? And it can't fill. Normally, this heart right here, this ventricle, when blood comes from the left atrium to the left ventricle, or from any atrium to the ventricle, your heart kind of compensates and stretches for that load, right? That preload. So in restrictive cardiomyopathy, we don't have any stretchiness right here. We can't compensate for the amount of blood coming into the left ventricle. So if we normally have 70% of the ventricle being filled, maybe we're only filling like 50% of the ventricle. That's just a good way to think of it. So this is a diastolic dysfunction. This is a filling problem. It's not a pumping problem like dilated cardiomyopathy. Okay, so this is pretty high yield for this subject. I would know all three of these, okay? The most common cause of restrictive cardiomyopathy is amyloidosis. And in PA school, you don't really learn too much about amyloidosis. You just want to have an idea what it is. This is a buildup of proteins called amyloids. It's an abnormal buildup, usually in organs like the heart. Kind of like hemochromatosis is a abnormal buildup of iron in some organs like the liver or heart. This is just a buildup of amyloid proteins. Sarcoidosis, you should have a good idea what this is. So in a vignette, right, if a 45-year-old African-American female with shortness of breath comes in, you do a chest x-ray, they have bilateral hilar lymphadenopathy, you pull an ACE level, it's increased, and she has swelling in the feet, cough, chest congestion, increased JVD, right? So she has sarcoidosis. She probably got restrictive cardiomyopathy as well. The vignette will have to associate these etiologies into the vignette so you know a correct answer choice to pick. I would remember all three of these. Just go ahead and embed that in your brain. Again, just heart failure symptoms. Because you have this stiff, rigid ventricle, right? Blood is going to back up to wherever's next. Does that make sense? So if the left ventricle is affected, then the blood's going to back up into your lungs, your pulmonary circulation. You're going to have cough, shortness of breath, right? Chest congestion. If the right ventricle is affected, then you're going to have peripheral edema. A high yield thing about restrictive cardiomyopathy on a physical exam standpoint would be this Kussmaul sign. And what this is when the person takes a breath, right, and you look at the side of their neck and their jugular vein distends. So it's increased JVD on inspiration. What normally happens is when you inspire, blood rushes back to your heart, right? But in this case, the ventricle is stiff and rigid and it can't fill properly, so it's preventing that blood from filling in that ventricle, and it's basically shooting it back to the rest of the body, which creates this JVD. Other edema, JVD, crackles, that should make sense. Okay, for the workup, this right here is a little bit different than the other cardiomyopathies, but obviously you're going to want to look at the heart with an echo. And usually if a vignette or a question is asking about findings of restrictive cardiomyopathy on an echo, it's going to say, a diastolic dysfunction, or the chambers aren't filling properly. Remember, they're going to have normal wall thickness and normal chamber size. Abnormal chamber size would be the dilated cardiomyopathy, right? Abnormal wall thickness would be hypertrophic cardiomyopathy. So if it says diastolic dysfunction or the chambers aren't filling properly, you probably have restrictive cardiomyopathy. And you'll do this initially, right? But for certain, and the boards like to ask this question, I had a question on it was either my EORE or my EOC into curriculum. What is the best test for confirming restrictive cardiomyopathy? Well, you want to see what the underlying disease process or the underlying cause is. So you need to do a biopsy. If it's hemochromatosis, right? How are you going to know it's hemochromatosis? A biopsy, right? Or if it's amyloidosis, you want to see what type of proteins are building up in that myocardial wall. So you're going to do this biopsy. So this is the most definitive test. This echo would probably be your better initial test. So treatment for this, the boards will only ask you to treat the underlying disease. So for example, if it's hemochromatosis, they got bronze skin, they have a little bit of cirrhosis in the liver, treat the hemochromatosis, do phlebotomy. If they confirm it's amyloidosis, I think and believe that this is kind of like an immunomodulator chemotherapy agent that you treat this with. Again, in PA school, you don't really learn too much about this disease, just know kind of what it is. But then sarcoidosis, this is a big one, and I could see them asking you about this. So say in your vignette that this person has sarcoidosis and they have associated restrictive cardiomyopathy with it, probably want to give them steroids, right? Because that's the treatment for sarcoidosis. And then again, if you have volume overload, if they're a little bit hypoxic, peripheral edema, stuff like that, you can give them a diuretic to treat that volume overload. So let's do a high yield vignette question. All right, let's get after it. A 46-year-old African-American woman presents with shortness of breath for 3 days. Her past medical history is significant for sarcoidosis. Lately, she has also noticed swelling in her feet and more coughing. On physical exam, you note 2+ pitting edema. A chest x-ray shows bilateral hilar lymphadenopathy. You decide, okay, let's stop right there. So from here up, right, you should know that this is a sarcoidosis flare, right? Or something. It has something to do with sarcoidosis. Right there, you should be thinking, And then when you look at this echo, right, you order this echo and it shows a filling dysfunction of the right ventricle. Sarcoidosis affecting the heart, you should probably be thinking restrictive cardiomyopathy, right? But the question asks, what 2 medications would be most appropriate to start? Well, you note that there's 2+ pitting edema. She's having increased shortness of breath and swelling in her feet, right? Probably want to put her on a diuretic, right? But what's the underlying cause of all this? What's the underlying cause of the restrictive cardiomyopathy? Right here. Bilateral hilar lymphadenopathy is almost whatever that word is. It indicates that she is having a sarcoidosis flare. What medication do you want to use for a sarcoidosis flare? Prednisone, a steroid, right? And then obviously, like I just said, you want to diurese her just a hair. So the answer is you want to give her furosemide, and prednisone to treat her sarcoidosis. So guys, that is restrictive cardiomyopathy. If you like this video, give it a like. Subscribe to the channel if you are not already subscribed. And that is the end of the cardiomyopathies. And we will see you in the next video.